it's very heavy, even if they have come to terms with it. So the psychosocial part of it, even though the lines are usually tiny, because we care about, we write lots about blood pressure or our respiratory, it's really, really important because this is their experience. And we want to make their experience, although it's not a nice thing to deal with, the kind of best experience that they can have and that their family can have. How nice would it be if their family came the next day and said, oh, how are you doing? Are you all right? And the patient said, yeah, my nurse is really great. She came and she sat with me and talked to me and made me feel happy or comfortable. That family member would then be like, I don't feel so guilty leaving him overnight, or I don't feel bad that I wasn't there because I had to go pick up my kids or whatever it might be. Because family do have a lot of guilt because they think I need to be there 24/7, but we are there 24/7. Yes, we have other patients, but we need to be aware of the things we need to do for each of our patients, and that's why care plans are really important in understanding where we are, what we need to do, and what time we need to do that. So cool. So now I'm going to give you, you've got your care plan there, so I'm going to give you some other examples, which is on the slides, I think. No, let me pull it up because it's on here. And I want you to look through these other examples and write them in your care plan. So there's 3 different ones. No, not that one. So this one. So that's the first case study, and I want you to, there you go, pull out things you think are important and the interventions that you would do in order to meet those trigger words or things that you feel are important for that patient. So when you're done the first one, just let me know and we'll go to the second one. There's 3 in total. While you're writing this down, I'll let you know that every day is different for these patients as well. So that same lady I was telling you about, the Buddhist lady at RPA, so I looked after her for about a week in a row, and she died on my second to last day. So the first 2 days I had her, she was restricted to bed. She was very lethargic and very tired, in and out of consciousness. Day 3, I walked in, she was wide awake. She was bubbly, sitting up in bed, and she wanted a shower, even though she hadn't been out for weeks. But she got out of bed, we used the 4-wheelie walker, she walked to the bathroom with assistance, had a shower, happy, talking to her family all day, sitting in the chair, and then I finished my shift, and the next day, she was unconscious. So your care plan will change each and every day, so you have to be aware and use the history that you have, but then also do an assessment on the patient every day as well, because things do change. Right, so that's the first one. This is our second patient. So you can just put that in the next column over. So hemiplegic means that they are paralysed or have no movement or sensation to one half of their body, whether it's the right or the left. And neglect means that they don't even know that, say you have, like this man, right-sided neglect, they would ignore their arm and their leg. They would think it doesn't even belong to them. And they might be like, oh, you know, so when they move, they might forget that's behind their back, might lay on it and actually not know that it's there for hours. And dysphagia means that they have difficulty swallowing. There's a few things on that one. Any questions about it? Or about the first one? Right? Everyone doing it? Okay. So this is our third case study or set of notes. So IV Lasix is to get rid of fluid. So if they're fluid overloaded, they pee it out. Dobutamine helps the heart to pump better. So that's what that means. Anything else? Yeah.
Battery ran out. Can I go back? You've got 19 minutes. Are we sure? Let's go. Okay.
Alright, so let me know when you're done and we'll we'll go through that. Alright, so we'll start with case study 1, and I want you guys to tell me what kind of interventions you might put on your care plan, or what categories of care this patient might need.
So assess the site where his butterfly is to
Yep.
make sure that's A-OK.
Yep. So we want care of this, like wound care or devices. You know, when you check your cannulas at the start of the shift, that'd be a similar thing. Yep.
Definitely needs some mouth care
Mouth
going
care.
on.
Yeah. Yep. Mouth care. So you can use swabs. There's also a medication called Milstat, which you can kind of drop in. They can suck on a wet swab as well, or ice. Yeah.
Wound dressing.
Wound dressing. Yeah. For his heel. What else, other than the dressing? What else might we need to do for his heel?
Device.
Yeah, an offloading device for his heel. If we don't have access to one of those, we can use a pillow, just so.
The heel booty things.
Yeah, or the heel boots, because even though it's unresponsive, you still having a pill under there is not going to distress him or anything, but might make the sheets dirty or something like that.
So his bowels aren't open, but he's not eating. Would you do anything about that?
No, probably not. No. Not unless.
changes.
Yep.
Yeah, or
Yep. He's incontinent of urine. Yep. Good. What about the fact that he's unresponsive? If he's unresponsive, he's probably not moving himself around, right?
No.
So what would you do?
Air mattress.
Yeah, an air mattress, pressure
Regular
care.
roll.
Yeah, unless the family state otherwise, right? Yeah. We talked about the butterfly, so making sure it's in the right place, it's not kinked, doesn't need to be repositioned, etc. Mouth care we talked about, that's really good. Hygiene, yes. Wound dressings and again pressure area care. What about family?
Yeah, check in with them, see how they're going.
Yeah. What might you ask them? Or what might you talk to them about? If they're there all the time, just sitting with a patient and you're obviously going to go in regularly and do your things, are you going to ignore them if they want to cover? Yeah, if they want to cover?
Yeah.
Yeah?
How they're feeling, if they want anything particularly done or
Yeah.
not done right now.
Yeah. We can make them a bed. We have those little pull-out beds. Are you staying? Can I make a bed for you? Do you want a blanket? Those rooms can get really chilly.
Yeah.
We're moving around a lot. They're not. They're sitting stagnant. Maybe they want a blanket or a cup of tea, coffee. Maybe ask them, is there anyone else that you need us to call? And also explaining what we're doing is really important. A lot of patients' families aren't from a medical background or a healthcare background, might not know what we're doing. They might be like, oh, why are you rolling them? Why are you touching them? What are you shoving into their arm or whatever it might be? So we need to talk to them and tell them, look, I'm just giving Bill some pain relief. We're just going to roll him so make him a bit more comfortable. And also, even though Bill is unresponsive, if the family wasn't there, we should still be talking to Bill.
Yeah.
Hey Bill, I'm just going to roll you. We're just rolling you now. We're just changing your sheets. He's still a person. He's not deceased yet. And even when they are deceased, we still should be treating him with dignity and respect. Very good. So case study 2. So he's just had a stroke, which has made him completely unable to move one side of his body. So he's got weakness and neglect, so he doesn't realise that half his body is his. And he can't swallow properly. He's got trouble swallowing, and when he does eat or drink, he coughs. Look at his diet. Speech. Yeah. So we can get a speech path review.
Make sure he's sitting up. Right.
Yeah. So obviously this guy's conscious, otherwise he wouldn't be able to eat or drink. If he was drowsy, we need to be like, oh, should I be feeding him? Sometimes the family is the one that's actually, they're worried. They're like, he hasn't eaten in 5 days, even if he's like in and out of consciousness, and they get really stuck on certain things. You'll notice, like some people want IV lines in because they're like, they need to have something because they're going to die of starvation or dehydration, which usually isn't the case. So they might, in somebody that has trouble swallowing, just give them a cup of tea or try feed them and cause problems. So with this person, we can get speech path in. If this patient is happy with having a puree or something like that, that's fine. If he really wants a cheeseburger, let him have a cheeseburger or whatever. But position him so that he's going to be in the best possible position to eat. Tell the family, look, if you're going to feed him this is the best way to do it. Like, don't use a straw, use a spoon to give him some water, or use a swab so that he can suck on it, or whatever it might be, to try and prevent, further issues. Because it can be uncomfortable for the patient. It can actually cause premature death. So if this patient isn't dying anytime soon, but because of this stroke he might end up dying in the next few weeks, you still don't want it to happen sooner than it has to be by causing him to have a pneumonia from aspirating. So yeah, being very vigilant with that and explaining to the family, you can feed him, just do it this way. So his IDC.
How's the hair?
Yeah.
Yeah.
Make sure it's clean.
Mm-hmm. So you want to make sure it's draining well?
Yeah.
Yeah. What about pressure area care with IDCs? Has anyone ever seen one?
Yeah, pinches of not even.
Yeah. So for both women and men, if we don't change the position or the side that the tape is on, it can actually cause a pressure injury because if it's sitting here on this side, it actually digs in. So we should be changing it regularly so that it's not in one place for a prolonged time, which causes a pressure injury. Yeah. Make sure it's not kinked. So having an IDC that's not draining because it's malpositioned or the balloon's in the wrong place can actually cause them to go into retention and make their bladder really full. And that's actually very painful. So for this patient who's not unconscious, that might be a source of pain or infection as well. So yeah, regular catheter care is really important. So he has some constipation associated with that, which is why he has the IDC in situ. So if you're not voiding properly, you can actually become quite constipated. So until his urine is draining properly, he might then have a good bowel motion. So we'll leave the catheter in until he does pass some stool. He might not, who knows. He's conversing with family and staff appropriately and he's worried about the future. Yeah, have a chat with him, see what he's specifically worried about.
He said meeting to the family as well.
Yeah, discuss with the family. Let the doctors know, like, look, this guy's not doing very well dealing with his condition. He might have been completely independent before this. Imagine going from what you are today to not knowing that half your body is yours, not being able to move, walk, eat properly. This guy might be 47. Who knows? But because of what he's got, he might, there's nothing we can do about it and it's really a palliative thing for him. So ensuring that he is involved actively in the decisions that he's making, he's conversing appropriately, his mental state is fine. So allowing him to make decisions. And as nurses, we can advocate for that. That's our whole role, is to be the patient's advocate. So letting the doctor know this is what he wants, or this is, can we discuss it with him, in front of him, with the family involved, so that it's a group discussion. It's not doctors making decisions on behalf or nurses making decisions on behalf of the patient, which is super important. Being aware, so knowing what is happening, it might just be he's worried about it because he doesn't know what's going to happen, or because no one's told him what his prognosis is, or what he's doing tomorrow. People just keep taking him to scans or whatever it might be. No one's actually telling him anything. That might be the source of his worry. And so if we actively engage him in his care, he might be a bit better with it, like, okay, I know what's going on, that's fine. Now the last one is Mr. 3. So he's similar to the first one, the example we did. So he's in decompensated heart failure, so really his heart's on his way out. He's having symptom relief, but no other medications. So the medications he's having are not to cure or treat the problem, they're for symptoms, to help him feel better. So he's on IV medication. What might we need to consider? Yeah.
Site, the date it was inserted.
Yeah, exactly. Good, making sure that that's all good. And maybe when his cannulas out of date, taking it out, does he really want to be pricked multiple times? Do we need to, try, because he's probably going to be hard access if he's overloaded, etc. Do we really want to try stabbing him 50 times to give him something that he doesn't really need? No. And he's got an IDC in. Yeah, so catheter care. He's got concentrated small outputs. So we can use that as an indicator if it gets less and less and less of his disease progression. We might need to give him IV fluids if the doctors want, if he's still having IV medications, maybe IV fluids is something we can give to help his urine output. His pain is minimally controlled at the moment.
So pain management.
Yeah. So so we talked about pain relief, like medication. What things other than medication can we do?
Positioning.
Yeah, because obviously as nurses we can't chart meds, right? We can give PRN if he has it, but we can do other things. So reposition him, heat packs, maybe distraction therapies, distraction techniques, and maybe, as soon as his family walks in, maybe his pain is not as bad as it was. A warm blanket, a shower, sitting in the chair, massaging his back.
Looking outside.
Yeah, we can do that, and I think people really forget that being stuck in a room is really, really traumatic. Everyone that's been in COVID, being stuck at home, it's really, people go crazy. We have chairs, we can take them out in wheelchair. The family can take them outside, sit in the courtyard, see the outside world, see their dog, bring their dog in. Those things are really, really important to somebody. That's their life, That dog might be their best friend and they haven't seen them in 2 months because they've been stuck in hospital for that long. Take him outside, take him to the front door, have their dog there, whatever it might be. He's a heavy transfer. He's got poor bed mobility because of his weight and his heart failure making him very weak. But he wants to have a shower this morning.
It says we'll get help, so that's possible.
Yeah.
If that's what you really want to do.
Yeah. So even though we're not trying to get him move because he needs to walk around, maybe the physios can help us out, assess what kind of equipment we need.
Yeah.
And then if we find out what equipment we need, maybe for the next when we hand over, we can tell them, Bob needed a facet, or Bob needed a hoist, or the standing lifter, so then they don't have to then go through the whole process again. So reading other people's notes, like the physio, previous notes, how they got him up before, to then find the information that we need to make sure that he is safe and we are safe, so that he can get what he wants. If he can't have a shower, maybe we can just give him a really nice warm bed wash in the chair or in the bed, and he might feel better about that. So trying to find out if we can use the first option, but then if not just saying, you can't shower, that's it, but providing additional options for him. Okay, so that's the care plan there. I don't think there's anything left on here. No, that's the end. So, what have you got out of today?
Lots.
Yeah?
Because I've never had any experience in palliative, so it's good to think of it.
Yeah. Well, that's good.
The different little things that make the big picture, really.
Yeah. Anybody else?
Just the importance of documenting properly on a care plan.
Yeah. Yeah. Because if it's not for you, someone, other people, it's not just our documentation. People look at our documentation, doctors, physios, we look at other nurses to be like, what did they do? So, I don't know, maybe they knew. So it is really, really important. We don't just so the stuff we put in a care plan, we can use a care plan on their journey board. So each patient, majority in this hospital, has their own little board. So we can write some of those interventions on there, like their super high falls risk, we need to use a hoist, or things to remember for my care. I need 4th hourly pressure care, or I have a subcut butterfly, please check it. So again, they might not need everything, they might only need one intervention, but yeah, very important to document it. And we can do that in multiple places, but a care plan is super important. Yeah. What do you think is something that you've learned from today that you'll implement? One thing.
Documenting better.
Documenting better, yeah.
Yeah.
Shift planner,
Yeah, using a shift planner, that really helps.
Yeah.
acknowledging the family a little bit more, rather
Yeah.
than just saying present.
Yeah, and I think for me, going through this, even though I've been nursing for a long time, it reminds me the patient isn't just a single patient. He's a patient, or she's a patient with a family, or a carer, or a mum and dad, or siblings, or children, or a friend, that they're not their own person. If you thought about if you had to come to hospital, who you would want involved, who you would want to know, or who you would want helping make choices for you or with you. And it goes the same way, especially culturally, a lot of our Indigenous people rely on their family, whether it's immediate or extended, their elders, their aunties. It's a big deal for them, and it's the same for us. I would want my husband involved in my care, or my mum, and I would want to be involved in my mum and dad's care. I would want the doctor to ask me, or the nurse to ask me, how are you doing? What do you think we could do better? Or them to listen to me when I say, I think you need some pain relief. Kind of thing. Very good. I'm glad that you've got something out of this to take to look after your next or your first patient that is in either the end of life or is palliative, because they're a very vulnerable group. They often don't get specific tailored care. They get their care because they're a cardiology patient, or they get their care because they're a stroke patient or a cancer patient, but they don't often get cancer care and palliative care, or cardiac care and palliative care. So it's really important to advocate for our patients and be aware of what we need and of what they need. So you should be able to go away from this today being able to pick out information from a care plan or from notes, whether it be a risk assessment, verbal or written handover, a journey board, and then you use those to plan your day, plan your shift, provide interventions, and you should be able to describe a few of the nursing interventions that can be employed for that patient group, and also be able to document those using a nursing care plan format. So again, I'm glad that you've got something out of this. Again, I really, really love palliative care, and if when we start out our journey as nurses, implement that straight away, no matter what setting we're in, it'll become habit and become part of our nursing practice, which is really, really important. So I just want to thank you for participating, for coming and for listening, and there is an evaluation form there, and just pop them on there and then we're done.
Thank you.
Thank you very much.